Thank you very much, Professor Dogra. Good morning, ladies and gentlemen. It's an absolute honor to be back in Delhi. I come from Delhi, so it's always nice to come home. And it's always great to follow on with lectures after Peter. So the topic of the talk that I was allocated by Dr. Bhandari this morning was on the oncological outcomes of robotic cystectomy. And it's quite a hot new topic with the amount of data coming across, but the best part is that whenever you look at PubMed and you look at oncological outcome, out of the 100 papers found, 99 are published by Peter. So, it's great to have him here too. So just to give you a brief background as to how I've been involved with this meeting, in June 2015, my cancer center, which is located north of London, was recognized and accredited by the Varikudi Foundation. So we're the third center in Europe to gain this recognition. And we're working pretty hard on not only projects such as the International Consortium for Collection of Cystectomy Data, but I'll be just showing you some exciting research that we're doing at the University of Hertfordshire, which I hope will be benefiting patients undergoing robotic cystectomy. I'm no veteran or a world expert in robotic cystectomy like Peter is, but my experience so far is having had trained both in the UK and US in fellowships. I've done about 60 robotic cystectomies with intracorporeal neobladders and conduits now. And I just feel that there's a need of some haptic feedback development with this procedure. So I'll talk to you about that in a bit. So my cancer center is just located north of London. So that's the M25. That's where Heathrow Airport is. And we have quite a big catchment, sort of approximately 1.8 million is the catchment of my cancer center. And we tend to do about 100, 120 cystectomies, most robotically per year. And I'm sure all of you are aware that the EAU next year is in London, so I hope to see all of you there in London itself. So let's just go back a little bit. Let's draw a page, because my talk, what I've done is I've tried to translate the oncological principles of what's out there with open cystectomy in conversion to robotic cystectomy, because I think it's progressing. It's work in progress as far as robotic cystectomy is concerned in most centers world over. So a radical cystectomy and a pelvic lymph node dissection is gold standard treatment for muscle-invasive bladder cancer. And for high-risk non-muscle invasive bladder cancer too. We've had BCG shortages in the UK recently, so we've seen a slight increase in the amount of people having cystectomies for primary high-risk non-muscle invasive bladder cancer, but now that shortage is coming to a close. And what's out there in literature is not only from the perspective of a radical cystectomy being gold standard with a pelvic lymph node dissection, but also neoadjuvant chemotherapy on previous data, now current data, indicating a 5% overall survival benefit. But I'll be summarizing the overall cancer-specific survival of what's out there with robotic cystectomy. So this was quite a good abstract which was presented at the AUA a couple of years ago. And if you look at robotic partial nephrectomies, you look at robotic prostatectomies, I think the jets have flown out. You know, there's a lot of push. A lot of urologists are confident in offering patients robotic prostatectomy and robotic partial nephrectomies. But as far as cystectomy is concerned, the debate continues not only from the perspective of the perioperative or the short-term outcome, but the oncological outcome is still being evaluated. So this looks at the complication rates of patients who have undergone a robotic prostatectomy, a robotic cystectomy, and a robotic partial nephrectomy. And it's quite obvious as to why robotic cystectomy hasn't taken off as much as expected. It's to do with the complications which are a lot to do with the bowel and so on, but hopefully with newer techniques, enhanced recovery, intracorporeal reconstruction, and so on, this will drop further down. So let's just go through an evolutionary pathway as to what's been happening with robotic cystectomy in clinical practice. So as far as robotic cystectomy is concerned, with Professor Menon doing the first one around the 2000 mark, it certainly led on to the establishment of robotic cystectomies from 2000 to 2005, in which techniques such as dissecting using staple guns, how to handle the pedicle, the degree of lymph node dissection, and predominantly improving on the surgical technique was the phase from 2000 to 2005. So these are pioneering world centers which started the procedure. A lot of emphasis took place from 2005 to 2010 on the next phase, which included intracorporeal reconstructions, which started predominantly with ileal conduits and translated down to neobladders. But what's happening at the moment? What is happening from 2010 onwards? There's some data on some prospective randomized controlled trials, predominantly set up to address the numerous questions which came up, evolving comparing open versus robotic cystectomy, not so much with laparoscopic. And there's a lot of push on enhancing recovery, especially in the UK. There's a big push on ensuring that patients get home much quicker. So length of stay is looked at very, very crucially in the national health system. So this is what we are marked on. And now we do have some early data on oncological follow-up, but again, it's around the 5-year mark, but longer-term data is in the process of coming out. So what is the oncological parameters one needs to look at as far as robotic radical cystectomy is concerned? So this is just from a UK perspective, and I'm sure it's similar in Europe and hopefully in India too, having done my first robotic cystectomy in India with Professor Kumar in Max in December. What we look at is neoadjuvant chemotherapy. So most of our patients with muscle-invasive bladder cancer in the UK will have neoadjuvant chemotherapy as a part of the multidisciplinary team management with the oncologist. But if you look at what predicts oncological outcomes includes what's picked up on the pathology. So this is the histology, whether a patient has a positive surgical margin, and the amount of lymph nodes that have been taken out during a cystectomy. So when I started doing robotic cystectomies, and I went across to Tim Wilson in the City of Hope to do my further fellowship training, what I realized was a lot of emphasis in high volume centers, not only to complete the ablated Brit spot on in a proper manner, but also spend time to do a proper lymph node dissection. Just picking a few lymph nodes out, and in the back of your mind, you've got the patient head down, you've taken 2.5 hours to take the bladder out, and the next focus is another 2.5 hours of reconstruction in the early parts of the learning curve. I think there's a compromise which can take place with lymph node dissection. So either you should work towards improving your lymph node dissection technique as a part of the cystectomy itself, or really take your time to do it, because it does make a difference from the oncological point of view. The recurrence which can happen after a cystectomy obviously include those in the pelvis, which can be local or regional, and more importantly, metastatic, which is associated with cancer-specific deaths. And I also present to you this morning some up-to-date 5-year survival data, which is cancer-specific survival, disease-free survival, and overall survival. So I'll just give you an example of what sort of pathology we're seeing in the UK. We're definitely seeing younger patients coming across to us with metastatic disease. We don't know why, but there is more metastatic disease being presented across. So this was a young guy who came across to me for a robotic cystectomy, 46, fit and well, had a TURBT for some hematuria, and he had T3N2 disease, had 4 cycles of GemCys, again as a part of our neoadjuvant protocol, and 4 weeks on the completion of his neoadjuvant chemo, he really showed excellent downstaging on his PET scan, CT, and MRI. So we proceeded with a robotic cystectomy with an intracorporeal neobladder for him. So the patient did really well. This was just a short video of what was done. And he stayed in the hospital for 6 days, had no problems whatsoever. And the technique that I tend to use for robotic cystectomy is exactly what world leaders like Professor Wickland have developed through and through. He had a good nerve-sparing robotic cystectomy, and so far has got a really good outcome. So the final pathology was T0. Surprise, obviously the neoadjuvant chemotherapy had done a really, really good job, and I managed to get 38 lymph nodes out, all of which were negative. And so far, till October, he's due for a scan actually next week. He's shown no signs of recurrence. So again, a successful outcome, even in the context of metastatic disease presenting in the beginning. Tim Wilson at Eris in Bilbao last year, when I met a few of you across there, made a very profound statement during his talk on robotic cystectomy. And he highlighted that the oncological steps and principles of a robotic radical cystectomy are the same as what's there in open surgery. And the reason for this very, very important statement is because the data that exists for open cystectomy is very strong, not only from the point of view of oncological outcomes, but about what's right and what's not right. So let's turn a page a little bit. Let's go back to the open cystectomy era. So what are the 3 aspects of surgical treatment that really make a difference or have an impact on the clinical and oncological outcomes of patients. So this is sort of robotic cystectomy era starting off, but what's out there with open cystectomies. So an important aspect is positive surgical margins, the number of lymph nodes that you take out, or the extent of lymph node dissection, and surgeon experience. And these have been proven time and time again on the basis of previous publications, with world leaders such as Skinner, that these three aspects do make a difference. So I'm going to break this down into a few main topics. But what's coming out from the open cystectomy era was that there needs to be some sort of standardized approach on the surgical technique. And that's what the ERIS group and different groups world over that do robotic cystectomy are working out as to what the standard of a surgical technique should be. So this is very, very important as far as robotic cystectomy is concerned. There's a lot of retrospective data which has been published from units looking at the experience, a lot of case series out there, but there are few randomized controlled trials which have been published comparing robotic versus open cystectomy. So the first trial, which was published by Dipin Parekh in the Journal of Urology, focused a lot on perioperative outcomes, blood loss, how the patients did when they got home, and in general what the gist was comparing open versus robotic cystectomy. And the second clinical trial, I think, was slightly more interesting, published in European Urology by Bocha and his group from MSKCC, which looked a little bit more on the oncological outcomes. So let's go and look at these two papers. So the first paper, published by Parekh in JUROL 2013, looked at 47 patients. So not a great number, but the data that he published was on 40 patients, because 7 patients, they didn't really have enough data to publish at that time. So as per Professor Wittgenstadt this morning, you've got data to support the difference between robotic and open cystectomy. Those of us who do it know that the blood loss is definitely lesser. There's no doubt about it. If you do it properly, use the correct energy sources, blood loss definitely does drop down. But what was surprising was in centers where surgeons were doing high volume surgery, they were really able to match their operative times, which was pretty good. And we've seen that in our center too. The length of stay was similar, and the complication rates were also pretty similar. So no sort of significant major complication in both groups. But this, I think, in real world practice doesn't really hold, because we do tend to see complications. But what they already published from the oncological parameters was not short-term or long-term oncological data, but they published on the positive surgical margin rate, which again were comparable. One would have thought there would be a difference, but they were comparable. And if you break down the oncological parameters that they published on, my concern was in this paper, have they done more robotic cystectomies on non-muscle invasive bladder cancer as against muscle invasive bladder cancer? So there was a slight difference. In the robotic cystectomy group, more patients there was a small breakdown of superficial bladder cancer, but again, the distribution was fairly even. But the interesting part was the lymph node dissection that was performed in the robotic cystectomy cohort was slightly more extensive, up to the level of the aortic bifurcation. So more people had it done. But again, as mentioned previously, the positive surgical margin matched, and they didn't have much data to suggest the oncological difference. But the profound statement that came out of this paper was that there was a need for a larger multi-center prospective RCT to look at more patient numbers and longer follow-up. Subsequent to this, in European Urology in 2015, Boucher from his Memorial Sloan Kettering group again published data on a slightly higher number of patients, 124 patients, but the data of only 118 patients was presented, looking at positive surgical margin rates and the amount of patients who presented with T3 disease and above. But again, fairly comparable. The positive surgical margin rates did match 3.6% to 4.8%, and the disease stratification was fairly similar. And if you break down the oncological data, the lymph node yield adjusted for the extent of dissection also showed no difference in the technique. So surgeons who were used to performing high volume open cystectomy with extended different degrees of lymph node dissection were now being able to match it with a robotic group 2. So the real question then comes up is, what is the correct degree of lymph node dissection during a radical cystectomy? Is it plucking 4 nodes out, 10 nodes out, 15 nodes out? No one knows, but I hope to address that question. And the confusion actually starts off with the nomenclature which exists. You want to do a limited, you want to do a standard, in which patient should you do an extended. So this slide just summarizes the anatomy of where lymph node dissections should be done. But again, there are more different classifications, such as level 1, level 2, and level 3. But most of the centers are doing level 3 or super extended lymph node dissections now in the context of robotic cystectomy, and that's what we aim to do too. If you go back again to the open cystectomy cohort, why is lymph node dissection important? So this particular paper, which was published in the New England Journal of Medicine, I've only got one paper into this journal, and I know how tough it is to get in. They looked at the difference of patients who had radical cystectomy versus neoadjuvant chemo and radical, and they had fairly robust data as far as 11-year follow-up is concerned. And they stratified their 5-year disease-free survival on the basis of the degree of lymph node dissection when they looked at certain subgroups. And in patients who had no lymph node dissection performed, that means you just took their bladder out and did their recon, their 5-year disease-free survival was 33%. Patients who had a limited lymph node dissection, it was 46%. But again, those patients had a slightly higher risk of local recurrence. But the patients who had an extended lymph node dissection certainly benefited with the 60% 5-year disease-free survival and a risk of recurrence of about 6%. And when they looked at the number of lymph nodes being resected during a cystectomy, less than 10 nodes was associated with a 44% 5-year disease-free survival, and more than 10 lymph nodes removed during a cystectomy was again associated with a benefit of a 61% disease-free survival. Further data from this paper also indicated that what happened to those patients in the long term who had a local recurrence. If a patient did develop local recurrence, which again we strongly believe is not good news, although now things have changed up as far as adjuvant treatment is concerned and there are new treatment methodologies coming out, it was seen that patients who had local recurrence, about 91% of them died from their disease in the long term, and 100% of patients with a positive margin died from their disease. So during a cystectomy, it is very important that when you're doing this operation, when you start doing robotic cystectomies, you ought to make sure that you're confident to make sure that the patient has a good oncological outcome and you really avoid a positive margin. And I'll talk to you about some research that we're doing with technology to help prevent that. So another paper from Peter. This particular paper published in European Urology in 2013 really set out the standardization of evolved approach for robotic cystectomy. We've seen some great videos this morning. And the recommendations which came out, I think, are fabulous, and we tend to follow these pretty strictly in my unit, in which the recommended lymph node yield was 10 to 14. You really need to work towards dropping the positive surgical margins down. But the acceptable surgical margin rates, although not in coherence with the previous data that I've just showed you, that in all cases it should be less than 10%, including your learning curve on the initiation. So you really need to audit your outcomes in all cases. But in bulky disease, a less than 15% positive surgical margin rate. And as far as long-term survival is concerned, the 5-year overall survival should be between 59 to 60%, and a cancer-free survival of about 62 to 68%. But in this particular paper, they also showed that if you look at the final pathology of a robotic cystectomy specimen, what are the associated risk factors with poor prognosis from the oncological point of view? And this included the presence of T3, T4 disease, patients who had lymph node positive disease, or patients who had squamous cell carcinoma diagnosed at the time of cystectomy were all associated. So this is a group of patients you need to be monitoring them even more closely than normal with your surveillance protocols, and think about adjuvant treatment like we do in the UK when we have pathology spring up in this group. So this paper looked at the recurrence patterns in patients after open and robotic-assisted radical cystectomy. So if you just break this cohort down, so there were 120 patients who had open radical cystectomy versus 263 patients who had robotic cystectomy. The surgical margin rate was a little bit higher in the open group. But if you look at the reason for that was because a lot of the patients who had T4 disease had open cystectomy. So there was a slight bias towards performing an open cystectomy in bulky disease as against those patients who had more non-muscle invasive disease. But the reassuring part from a cohort of about 260 patients was that none of the patients had any degree of port site metastasis, although there are a few case reports of this taking place in literature. Again, when you look at the risk of local recurrence, it was about 23. So in the open cystectomy group, in the same paper comparing open versus robotic cystectomy, local recurrence 23%, 18%, so fairly similar, not a big difference. And again, none of the patients had any upper tract, had urothelial carcinoma, which had come up later on follow-up either. So let's just go to what's been summarized recently. So we've just submitted this paper from my unit, a Cochrane review on invitation, comparing robotic versus open radical cystectomy, which should be out there next month in literature. And we did an up-to-date review up to all the papers published January 2016 on not only perioperative outcomes, but also some oncological parameters. And what we've seen is that there have been 4 suitable meta-analysis included in this Cochrane review, and the meta-analysis have showed that there's no significant difference between positive surgical margins in the robotic and open cystectomy group. So this holds true from the perspective of the randomized control studies, and further meta-analysis also have confirmed that, which is fairly reassuring from the perspective of the robotic cystectomy cohort. Now we've got short-term outcomes, but what's out there? Long-term outcomes were published in 2015 from the International Robotic Cystectomy Consortium. We're a part of that database now. And this particular database considered 2,187 patients from 37 institutions and 17 countries. But those patients who had 5-year follow-up were included in this publication, which was a good group, which was 743 patients. And when you break the data down, again, the median age was 69 years. Most of the patients, 82% of them, were male. Operative times were about 438 minutes. Most of the patients had organ-confined disease at the time of cystectomy. Positive margins in 8%. So again, in concordance with what was picked up. But the median lymph node volume, the amount of lymph nodes removed, was 16. So more than 10. Which has been proven to improve 5-year specific survival. Only 15% of these patients received neoadjuvant chemotherapy, which is surprising, although trends now are certainly towards giving neoadjuvant chemotherapy. More patients will now, if we look at this data 5 years down the line again, will show a slightly higher percentage. But a good amount of patients had an extended pelvic lymph node dissection. The pathology in 68% of patients was TCC, 26% of patients was SCC, and as far as T-stage is concerned, on staging pathology, a majority of the patients were less than T2. 24% of patients in this cohort had adjuvant chemotherapy on the basis of their adverse histology. So let's look at the follow-up, 5-year follow-up coming up. So the local recurrence rate was 11%. Metastatic recurrence was 29%. So the question is, should more patients have had neoadjuvant chemo? But the median time to cancer-specific death post-cystectomy was 14 months, and the median time to non-cancer-specific death, a lot to do with the surgery possibly, and comorbidities of these patients who were some of these patients could have had higher morbidities, was about 10%. So in comparison to the open cystectomy cohort, this is what the data from this paper has indicated as far as recurrence-free survival, cancer-specific survival, and overall survival is concerned. So recurrence-free survival is about 67%, cancer-specific survival is 75%, and overall survival is 50%. So comparable to open cystectomy series. But what's been picked up is case selection is very, very important in patients undergoing robotic cystectomy. But the patients who do really well are those who have T2 disease or less on initial staging pathology, those patients who have N0 disease on final pathology, and those patients who have negative margins. So if you've got these 3 parameters springing up post-cystectomy, I think you are on a winner as far as their overall survival is concerned. There's been a lot of push, like we've seen this morning, there are lots of amalgamation and techniques taking place for intracorporeal reconstructions, be it conduits or be it neobladders. So I think it's important also to look at whether there's a difference in these two techniques as far as oncological data is concerned. So the ERIS Scientific Working Group looked at about 602 patients who underwent intracorporeal reconstructions. And if you look at the disease recurrence variance which took place in this group, the recurrence patterns, the overall recurrence was seen at about 18.6% of patients. And the difference that you can see is this is the local recurrence pattern in patients who've undergone ileal conduits intracorporeally or neobladders intracorporeally. And there is, a slight increase, 9.4% in the ileal conduit group. Probably you'll do an ileal conduit in patients who you expect who have very bulky disease or who possibly have more than T3, T4 disease at the time of a robotic cystectomy. We certainly do not tend to do robotic cystectomies on patients who have T4 disease. We tend to do them open. And as far as distance recurrence is concerned, it's very comparable. So the conclusion of this was, first of all, it was the largest multi-institutional cohort of patients who had undergone an intracorporeal robotic cystectomy. And the median term survival outcomes were comparable to those of open cystectomy. But there was, what came out of this group was the oncological or local recurrence data was comparable to the intracorporeal approach. So I'm just going to spend the next couple of minutes just talking to you about some research that we're doing with the Variguri Foundation at my center. So we've developed two specific research projects on patients undergoing robotic cystectomy. I think haptic feedback is important for those of us who do open cystectomies. It's important to get a feel of the tissue, and especially in T3, T4 disease, it can make a difference as far as positive surgical margins are concerned. That's what we believe in. And we've also developed something called a cytokine-guided robotic surgical project to enhance patient recovery, to super enhance patient recovery post-robotic cystectomy. So this is just an example of where I think haptic feedback is important. So I'm just preparing the ureter, which sometimes I forget to do too once the bowel's been mobilized. And this patient's got a really bulky sigmoid. I'm just transposing the ureter across in preparation for the Wallace anastomosis. And I think haptic feedback would be a little bit useful to just give me a gauge as to if there's any resistance behind the sigmoid, how hard I'm pulling on the ureter, and so on. So what we've done is I've got a haptic feedback group for which I'm the principal investigator, and we've got a group of engineers who are working together. This picture